In this video, we will be discussing about the collateral circulation in vena caval obstruction. Now, all of us know that the venous blood in our body should ultimately be reaching the right atrium of the heart. For this purpose, we are having two vessels that are opening into the right atrium. One is the superior vena cava, which is draining the blood from the upper half of the body, and the other is the inferior vena cava, which is draining the blood from the lower half of the body. So what happens when there is obstruction in either of these vessels? How does the blood reach the right atrium? First, we will see what happens in inferior vena caval obstruction. When there is inferior vena caval obstruction, the blood from the lower half of your body cannot reach the right atrium. The only other unobstructed vessel that is now opening into the right atrium is your superior vena cava. So, logic dictates that we should get the blood from the inferior vena cava to the superior vena cava, and that will take the blood into the right atrium. So, how do we go about doing this? The first one, the easiest one, or the most obvious one would be via the azygos. Now, all of us know that the azygos arises from the or as a continuation of the lumbar azygos, which arises from the posterior aspect of the inferior vena cava, or it may arise by the union of the right subcostal and the right ascending lumbar. Whatever the case may be, we know that it is in communication with the inferior vena cava. We also know that the azygos is ultimately opening up into the superior vena cava. So all we need to do when there is a block is get the blood into the azygos, make it flow up into the superior vena cava, and from there it will reach the right atrium of the heart. Another method is to utilize the veins on the anterior abdominal wall. We all know that the umbilical level or the umbilicus acts as a watershed line. That is, the veins above the umbilicus drain into the superior vena cava, and the veins below the umbilicus drain into the inferior vena cava. So all we need to do is establish a continuity between the two sets of veins. So in the supraumbilical part on the anterior abdominal wall towards the midline, we have the superior epigastric vein, and more laterally we have the lateral thoracic vein, which drains into the axillary vein. In the infraumbilical part, we have the inferior epigastric towards the midline, and more away from the midline we have the tributaries of the saphenous, namely the superficial epigastric, the superficial circumflex, the superficial external pudendal. Of these, the one that we are most interested in is the superficial epigastric vein. Remember this, superior epigastric is supraumbilical and drains into the SVC. Superficial epigastric, on the other hand, is infraumbilical and drains into the IVC. To better understand this, we will have a look at this diagram. So here you can see towards the midline the superior epigastric vein. The superior epigastric vein is draining into the brachiocephalic and then into the superior vena cava and then into the right atrium. Below the umbilicus, we have the inferior epigastric vein, which drains into the external iliac and then the inferior vena cava and then into the right atrium. So we need to establish continuity between the superior epigastric and the inferior epigastric vessel. So blood will flow from the inferior epigastric into the superior epigastric, brachiocephalic, superior vena cava and the heart. Now what happens? Let's look at the veins more laterally. We have the lateral thoracic vein, which is draining into the axillary vein, into the brachiocephalic, superior vena cava and the heart. Below the umbilicus, we have, as we mentioned earlier, the superficial epigastric, which is a tributary of the saphenous, okay, which drains into the femoral into the external iliac, into the inferior vena cava and the right atrium. So now we have to establish continuity between the lateral thoracic vein and the superficial epigastric vein. So the continuity here is by a connecting vein. You can see the connecting vein here. That is the thoracoepigastric vein. So the thoracoepigastric vein connects the superficial epigastric and the lateral thoracic vein. So when there is block, the blood flow will be superficial epigastric to the thoracoepigastric to the lateral thoracic, axillary and to the brachiocephalic and the superior vena cava. That is how the blood flow will be in inferior vena caval obstruction on the anterior abdominal wall. So in addition to the azygos and the veins on the anterior abdominal wall, we have another route for the blood to flow in inferior vena caval obstruction, and that is via the vertebral venous plexus. So in the lumbar region, this is the inferior vena cava. Here you can see the lumbar veins that are draining into the inferior vena cava. Now if you follow the lumbar veins posteriorly, you can see that it is connected to an intervertebral vein. These intervertebral veins connect to the vertebral venous plexus. So ultimately, the inferior vena cava is in communication with the vertebral venous plexus. All of us know that the vertebral column is in continuity with the cranial cavity. So the blood from the intervertebral venous plexus will be communicating with the sinuses inside the cranial cavity. These cranial sinuses ultimately drain into the internal jugular vein, and that is how it exits the cranial cavity. After exiting, the internal jugular vein ultimately joins the drains into the superior vena cava, and then the blood will reach the right atrium of the heart. Now this point has got a special significance. If you look closely, these are the lateral sacral veins and these are the lumbar veins. Both are communicating with the vertebral venous plexus, and via that it is communicating with the cranial sinuses. So if there is a malignancy of the pelvic organ, the pelvic region is drained by these lateral sacral veins. Okay. So if there is a malignancy in the pelvic region, the metastasis can reach the vertebral column and the cranial bones via this route. So to recap, in IVC obstruction, we have to get the blood from the IVC to the SVC, and this is by three routes. One is by the azygos, two, it is via the veins of the anterior abdominal wall, and three, it is via the intervertebral veins and the vertebral venous plexus. Now let's see what happens when there is SVC obstruction. Now SVC is a little different from the IVC because there is one special vein that is joining the SVC just before it enters the heart, and that is the azygous vein. So we can classify SVC obstruction into obstruction above the level of the joining of the azygous and obstruction below the level of the azygous joining the SVC. So what is the difference? If the obstruction is above the azygous joining the SVC, all we need to do is get the blood from the SVC above the obstruction into the azygous, and the azygous will carry it back to the SVC below the obstruction. That is, it will bypass the obstruction, and via the SVC itself it will open into the right atrium. The other scenario would be when the obstruction is below the joining of the azygous. In that case, we cannot have this trick. We have to get the blood down into the IVC, and from the IVC the blood has to be carried to the right atrium. So let us look. First, obstruction before entry of the azygous. So if you look closely in this diagram, you can see the azygous vein, and the azygous is going and meeting the superior vena cava. So let's say the obstruction is above this level. Can you see another vein here? This vein? This vein is the internal thoracic vein. The internal thoracic vein drains into the brachiocephalic vein. What we should do is get the blood above the obstruction into the internal thoracic vein. The internal thoracic vein tributary is the anterior intercostal vein. We all know that the anterior intercostal vein communicates with the posterior intercostal vein, and all of us know that the posterior intercostal vein drains into the azygous. So the route would be get the blood into the internal thoracic, from there into the anterior intercostal, from there into the posterior intercostal, and then into the azygous, and then the azygous will bring it back into the superior vena cava after the obstruction, and then into the heart. So that is the route you go for when the obstruction is above the entry of the azygous. If it is after the entry of azygous, all you have to do is connect it to the IVC. So as we have discussed earlier for IVC obstruction, same thing, same collaterals, only difference is the direction of blood flow will be reversed. Instead of going from below upwards, the blood will flow from above downwards. So you can have it via the SVC into the inferior vena cava, and that will take it to the heart. Then we have the veins on the anterior abdominal wall, and the blood will flow from above downwards. So from the superior epigastric into the inferior epigastric into the external iliac, inferior vena cava, heart, or via the lateral thoracic, thoracoepigastric, superficial epigastric, ultimately again into the external iliac and the inferior vena cava, and then to the heart. So those are the routes when there is SVC obstruction. So SVC obstruction you have to classify as before the entry of the azygous and after the entry of azygous. If it is before, you redirect it in the thorax itself and get it into the azygous, and it will directly drain back into the superior vena cava itself. It will not go to the inferior vena cava. If it is after the entry of the azygos, we have to shunt the blood into the inferior vena cava, which will carry it to the right atrium, and it has the same pathway as IVC obstruction pathway. Only difference is the direction of blood flow will be reversed. Now, vein obstruction would not be complete without having a short note on portal vein obstruction. Portal vein is a set of veins in the GIT, that is draining the blood from the gastrointestinal tract and the organs that are related to the GIT. The products of digestion of carbohydrates, proteins, nutrients, products of hemoglobin catabolism, etc. are all carried and they are ultimately taken to the liver. So here you can see the portal vein. This is the portal vein, and you can see its formation here, and this is its termination inside the liver. And in the liver, the blood will be terminating in the hepatic sinusoids, and they will be carried and ultimately they will join and drain into the inferior vena cava. So you have a portal system and you have a systemic set of veins, two sets. And portal system is important because it is acting as a reservoir of blood, and they contain almost up to 1/3 of the total volume of blood in the body. So if there is obstruction in the portal system, the blood will be redirected to the systemic circulation. There are 5 sites where this redirected flow of blood will take place. These sites are called the sites of portosystemic anastomosis. They are: first one at the lower end of the esophagus, okay, between the esophageal tributaries of the accessory hemiazygos and the esophageal branches of the left gastric. The second site is in the rectum, between the in the anal canal, between the middle rectal and the inferior rectal veins. The third one is in the region of the umbilicus, the para-umbilical veins and the superficial veins of the anterior abdominal wall. Then we have one on the inferior surface of the diaphragm, between the phrenic veins and the hepatic veins. And the fifth one on the posterior abdominal wall. So what we must remember, whenever there is collateral circulation, there will be dilatation of these vessels. This is because there is increased blood flow due to the shunting of blood from one system to the other, be it caval anastomosis or portocaval anastomosis, whether it is between the superior vena cava and the inferior vena cava, or the portal system and the systemic veins. Now, the most obvious dilatation that we can understand or we can see is around the umbilicus. And from the above discussion, we have figured out that there is dilatation of veins when there is SVC obstruction, there is dilatation when there is IVC obstruction, and there is also dilatation when there is portal vein obstruction. So how do we differentiate, or how do we figure out which obstruction is causing the dilated veins around the umbilicus? So for that we have to check for the direction of blood flow. The first thing to do is see the vein and empty the vein. Empty the vein using both fingers. Okay. After that, once a segment of vein is empty, you lift one finger, okay, and see if it is filling up and the direction of it filling. If it is not filling, try lifting the other finger and see whether the vein is now being filled or not. By that way, we can see whether the blood is flowing above, below, towards the umbilicus or away from the umbilicus. So based on this, we can decide the obstruction is in which vessel. So if there is SVC obstruction, all the veins will show filling from above downwards because the blood is flowing from the SVC to the IVC. In inferior vena caval obstruction, the blood flow will be in the reverse. That is, the veins will fill from below upwards because the blood is moving from the inferior vena cava into the superior vena cava. And if there is portal obstruction, you will see that it is keeping in line with the watershed line. That is, the veins above the umbilicus will go upwards. The vein below the umbilicus will go downwards. That is, the veins will radiate away from the umbilicus, a star-shaped pattern. That is how you determine the site of obstruction or which vessel is obstructed. So, to recap, we saw SVC obstruction and all the alternate pathways. We saw IVC obstruction, the alternate pathways, portal obstruction and where all the portosystemic anastomosis will be, and we stressed upon the one around the umbilicus because that is the one that you are most commonly seeing. In the other sites, which I would like to mention, one, the lower end of your esophagus, one site of portocaval anastomosis. That is the reason for hematemesis because there is rupture of these vessels. When they are dilated, they are very delicate and when they can rupture easily. And in the anal canal, between the middle and inferior rectal, that is the reason for internal piles. Dilatation of these vessels is responsible for internal piles. So caput medusae was dilatation of vessels around the umbilicus, and we also discussed how we could differentiate between the different types of obstruction based upon the direction of blood flow in the veins surrounding the umbilicus. Thank you.